have shown significant lower survival benefit in lung adenocarcinoma, not in metastatic setting, but now in adjuvant and neoadjuvant setting also we are using immune checkpoint inhibitors. However, there has been inter-patient heterogeneity. Even if the patients are having high TMB, high PD-L1, sometimes they are not responding to immunotherapies. So when they try to look back, why this is happening, they found out there are certain tumor intrinsic genetic mutations which modulate the tumor immune microenvironment, and therefore they modulate the therapy response. So one of these mutations were actually KEAP1 mutation, which is associated with shorter survival in lung adenocarcinoma patients, particularly in the presence of STK11 and KRAS alterations. So coming to a little bit about KEAP1 and NRF2 axis. So KEAP1 basically helps the cells in managing the oxidative stress through NRF2 axis. So KEAP1 binds NRF2 when there is no oxidative stress, when cell is normal. When there will be any oxidative stress, this KEAP1 will release NRF2, which will go intranuclear, and it will promote the gene encoding the antioxidant response elements. So that's how this KEAP1 NRF2 axis is important for normal cells to help to combat oxidative stress. But cancer cells take the advantage of this axis by using this axis to evade the effect of anti-cancer therapy like chemotherapy, radiotherapy. So KEAP1 NRF2 has been shown in, it occurs in almost 20 to 25% of lung adenocarcinomas. More than that, only RAS and TP53 mutation, this is the most common, this mutation occurs in 20 to 25%. And not only this promotes the proliferation of the cancer cells, NRF2 helps in promoting immune evasion also. So how does this? So NRF2 decreases the infiltration of CD103 dendritic cells in cancer tumor microenvironment, and that's how the proliferation of CD8 and activation of CD8 T cells get decreased, and these cells become resistant to immunotherapy. However, the study has not been consistent regarding the effect of KEAP1 on immunotherapy. There are conflicting results. Some KEAP1 mutated tumors treated with immune checkpoint inhibitors have done better when they were compared with chemotherapy. Like in a retrospective study in China, they have shown that the KEAP1 and NRF2 mutated tumors did better when they were compared with chemotherapy. And similarly, small cohorts of Keynote 042, where one arm was pembrolizumab, one arm was chemotherapy, it was shown that the arm containing pembro was doing better. However, others have reported inferior outcome, like in MSKCC study of 69 patients. They have shown that the KEAP1 mutations do uniformly poorly even if they are treated with immuno, chemo, or radiotherapy. Similarly, in district trials also, all the arms containing like durvalumab arm, durvalumab tremelimumab arm, or chemotherapy arm have done poorly. So to evaluate what is the effect of KEAP1 mutation, actually they have done this study. So they have tried to look upon the clonality of KEAP1. So KEAP1 clonality or LOH prediction may help to identify different classes of KEAP1 mutations. So there can be deleterious mutations, however there can be some mutations which have retained sensitivity to immune checkpoint inhibitors. So the methodology used in this study, it's a retrospective study for the clonal evaluation of KEAP1 mutations. They have used VAF and TP, like variable allele frequency and tumor purity, and they have taken this from MSK mid-tropism cohort, which is a cohort of 25,000 patients comprising of 50 different tumors. Among this cohort, they have selected NSCLC population, they have analyzed VAF and TP, and they have found out how the clonality could be established. And another model, the Dapaknoth model, was used for this study to predict the clonality. So to classify KEAP1 mutations as clonal with LOH and clonal diploid subclonal mutations. So this was the flow chart. So MSK metropism, 2,550 NSCLC patients. They have done back TP ratio analysis. They have used Dapaknoth models. They have classified them as different mutations, and the impact of these mutations were tested in 2 cohorts of lot patients treated with immune checkpoint inhibitors. And these immunological correlates were investigated using whole transcriptome sequencing and multiplex immunofluorescence study. So for the survival analysis, they have excluded the patients who were having EGFR mutation as they are exclusive with KEAP1, and those who are having missing TP data or multiple KEAP1 mutations. results, they have shown that both Kappa growth model and VAP-TP ratio intercepted this clonality prediction in a better way. Both the majority of putative mutations clustered within the highest tertile of VAP-TP ratio. They have shown the mutational enrichment analysis have shown that the KEAP1 having LOH group was enriched for TP53 mutations. They had high TMB and they had high fraction of genome altered compared to CDSC and wild-type mutations. Not only this, the metastatic burden also was quite high in the LOH arm compared to CDSC arm and wild-type arm, and the number of brain metastases were more. When they tried to analyze the PFS and in these patients treated with immunotherapy, they have found out the arm which was having LOH mutation, they have done poorly compared to the other two arms, and the risk of progression was almost 2.5 times higher in the LOH arm. Similarly, for OS also, the risk of death and progression was 2.5 times higher in the CLOH arm compared to CDSC arm and wild-type arm. When they try to look upon the immune genomic features, they have shown the lymphocyte infiltration, interferon gamma response, macrophage regulation. These were low in LOH arm compared to CDSC and wild-type arm, and then they have shown that they are immune deserted compared to the CDSC arm, which were immune enriched. They have also shown that the wild-type tumors had more expression of PD-L1 positive T cells and CD8 positive T cells compared to CLOH arm. It can be seen here in multiplex immunofluorescence study. So these are associated with low immune cell infiltration. You can see the Violin plots. So LOH had low total CD8 positive T cells, low total PD-L1 positive T cells compared to CDSC and wild-type, and that was significant actually. So coming to conclusion of this study, they have shown that the advanced lung adenocarcinomas who have received immune checkpoint inhibitors and whose tumors carry putative LOH mutations, they experience inferior survival outcome compared to those with wild type. And the KEAP1 CDSC tumors were similar to having KEAP1 wild type outcomes in lung adenocarcinoma. So there are various mutations which are actually not changing the outcome. So if we analyze the KEAP1 mutations, there are mutations which will have deleterious effect and some will not have deleterious effect. And LOH mutations, where it is present, it exhibits an immune cold tumor microenvironment. Future developments at sapanisertib has been coming, which is a dual mTOR inhibitor, as preclinical data has suggested that IMNF2 upregulates the mTOR pathway, and that's how this molecule might help in dealing with the tumors who are having this KEAP1 mutation. Similarly, another glutaminase inhibitor is coming because these mutated tumors are dependent on glutaminolysis, and the inhibition of glutaminase enzymes might result in decreased bone and radiosensitization. Thank you, everyone.
So can I ask one question? So if the patient is PD-L1 more than 50% and has KEAP1 mutation or LOH, what will be your first line treatment option?
The authors concluded, like, if KEAP1 mutation is there and PD-L1 is high, so you shall combine immunotherapy along with chemotherapy. So in the tumors who didn't have KEAP1 mutation, you can just give immunotherapy. But by this, they have shown if you are combining both the things, then the survival might improve, even if the patients who are having PD-L1 high.
Thanks.
Thank you.